Hi everybody, this is Dr. A. We're going to cover nervous system diseases as part of clinical chemistry. This is chapter 8 of Larson's clinical chemistry. Alright, so the nervous system disorders can result from impaired development. So it could be congenital or exposure to toxins and things in utero, birth trauma, degenerative processes, so this is where you get to dementias and Alzheimer's, and deposition of abnormal proteins. And those, in part, that could also be Alzheimer's and dementia, but we're also thinking of things like CREUTZFELDT-JAKOB and mad cow disease, the ruptured arteries, and so it would be like hemorrhages, strokes, etc. And also can be caused from routine immunization. So just saying that with routine immunization, it is not a no-risk kind of scenario. There are some risks, and some of those risks do include some of these diseases we're going to look at. All right, a little quick review of nervous system anatomy. So the central nervous system is made up of your brain and spinal cord, and it controls the rest of your nervous system and interprets signals and responds in accordance to it. The spinal cord is a big highway, really up and down from your brain, but the spinal cord does also house like reflexes, and so there's a certain amount of control also that occurs in the spinal cord. The peripheral nervous system is made up of the sensory neurons and the motor neurons. Obviously, the sensory neurons would be sensing things from outside the outside world and bringing the information into the central nervous system and into the brain. So that's input. So that could be vision, smells, taste, etc., but also feel of touch, and interpretation of the world around you. And then the motor neurons allow you to react to your sensory input and move about, carry out certain actions, etc. Within the peripheral nervous system, there's the autonomic nervous system and the somatic nervous system. So the autonomic nervous system controls involuntary functions, so things such as digestion, heart rate, your default breathing rate, etc. Somatic nervous system carries out all the voluntary things, so movement, so just speaking is voluntary, moving around, walking, getting up, sitting down, all the things that you can choose to do or not do. So the central nervous system is surrounded in 3 layers of membranes to protect it. And those membranes starting from so you have the brain, and then you have the pia mater on top of that, and then the arachnoid matter, and then the dura mater, and then the skull or the vertebral spaces. So underneath the arachnoid matter, there's a subarachnoid space, and that subarachnoid space is where you find the spinal fluid. And the function of the spinal fluid is to cushion in the brain and spinal cord and to maintain a controlled environment, bringing nutrients in, flushing waste out. These membranes, along with the spinal fluid, are basically responsible for the blood-brain barrier, meaning there are substances that are in the blood that are not meant to cross into the bloodstream. Now, you do have to know that there are some things that will cross over. So a lot of little peptides can cross over, cytokines and hormones, and there's things that cross, but some of the bigger, think bacteria is really not supposed to be there, bigger proteins, etc. Certain drugs shouldn't cross over into the brain. And so if there are abnormal substances that are found in the spinal fluid, then it could indicate damage to that blood-brain barrier, and it can be compromised, and it can get inflamed, and things can cross over. So a little bit about the peripheral and the autonomic nervous system. So again, the peripheral nervous system is composed of 12 pairs of cranial nerves and 31 pairs of spinal nerves. All of these come out from the central nervous system, and again, bringing information in and out of your body. And the autonomic nervous system, as we mentioned already, controls your involuntary processes, but it can be further subdivided into sympathetic and parasympathetic. So within any body system, sympathetic and parasympathetic are always going to have opposite effects, but we're still within autonomic, so things that we don't voluntarily control. For example, for the heart, the sympathetic nervous system, which is kind of more of your stress response, your activity, you're doing stuff, and it doesn't have to be anything bad. It could be exercise, for example. The sympathetic nervous system then would up your heart rate, whereas the parasympathetic nervous system, if it sends impulses, and it would lower your heart rate. So if you're exercising, jogging, running a marathon, your sympathetic nervous system would kick in to up your heart rate. But then later, after that is concluded and you're resting, then the parasympathetic system, nervous system then would lower your heart rate. This occurs also with breathing. And now, the parasympathetic nervous system can also switch on certain functions. So, generally speaking, the parasympathetic system is your rest, digest, and sex, if you will. So, signals of the parasympathetic system then would turn on those functions. So, the functions of resting, the function of digesting, so digestion gets started from parasympathetic nervous system impulses, and sex also. You need good parasympathetic nervous system responses, and things that turn it off are going to be sympathetic nervous system signals. All right, peripheral and central nervous system are made up of neurons, and neurons have an axon, a body, and a dendrite, and the impulses are always going to flow from dendrite to body down the axon to the next neuron. In the peripheral nervous system and in parts of the central nervous system, neurons are insulated by myelin sheath. All of the peripheral nervous systems, they are insulated. Within the central nervous system, if it's white matter, it's insulated by myelin sheath, and it's usually basically those areas are relays of information going up or down into the brain or out of the brain and spinal cord. But if it's gray matter, then those neurons are not insulated, and they connect and they help make connections, interpretation, thinking, reactions, etc. So let's start with the different diseases. So we're going to start with neural tube defects. So this is, we'll start at the beginning, if you will. So these are congenital. They happen in utero, and they are defective closures of the neuropores. The neuropores are an opening in the either anterior or posterior end of the neural tube of the developing embryo. So there are several types of neural tube defects. There's anencephaly, meaning no brain. So it's the most severe form of neural tube defect, and the skull and brain fail to develop properly, and so parts of it are missing. Then the next one, you have open neural tube defects. There's hydrocephalus there, and this is where the neural tissue is exposed to the outside and the spinal fluid can leak out. So that is why it's an open neural tube defects. And then closed neural tube defects are spinal bifida is a good example. Spinal bifida only involve the spine. There's an abnormal formation, but its spinal fluid is not leaking out of the body. So for example, here are a couple of those. You have the meningomyelocele, where so this is the abnormal protrusion, this abnormal closure in the meningomyelocele. The spinal cord is actually protruding through here, through this abnormal opening, but this is actually closed to where it won't leak. And a meningomyelocele just contains basically membranes and spinal fluid, but the spinal cord is actually still in the vertebral column. To detect these, part of the prenatal workup, we do the quad screen, which includes alpha-fetoprotein, HCG, estriol, and inhibin A. And we're screening for a lot of different conditions that can happen in utero. And so if the alpha-fetoprotein is elevated, then that would be an indication of neural tube defects. Next is cerebral palsy. That is a permanent motor dysfunction with lack of coordination, spasticity, meaning spasms, and paralysis, meaning cannot move, usually limbs or head or something. It is usually caused by a brain injury. The brain injury could occur due to prenatal conditions, birth trauma, or low birth weight. This is a leading cause of childhood disability that affects function and development. And the lab tests that we do are usually simply to rule out other conditions, but not specifically to diagnose cerebral palsy. Hydrocephalus is a disturbance of the spinal fluid flow formation or absorption, which leads to excess or increased volume of spinal fluid. And one of the symptoms are the characteristic feet that feel stuck to the floor. And also babies with hydrocephalus will have like a bigger brain here. They'll be swelling because that their plates, all their plates have infused, and then the spinal fluid is putting pressure, and so they'll have a little bit bigger head right here. So there are no blood tests to diagnose this diagnosis. Spinal fluid studies could be warranted, again, to rule out some type of infection. Hematomas and hemorrhage. So hematomas are bruises, hemorrhage is bleeding. These can occur in several areas, but the epidural space, subdural space, and subarachnoid space are three areas in which it can occur. In the epidural space is the space between the bone and the topmost membrane, and so that would be bleeding between the dura mater and the bone. And this space is, around the brain and stuff, and around the spinal cord. We usually know the epidural space because that's one of the places we can put in injections in the spine, in the lumbar area, to get medications to the central nervous system. The space below that is the subdural space, so this is the space underneath the dura. And so you'll have bleeding. There's bleeding between the dura mater and the arachnoid membrane. And then, of course, then the last one is the subarachnoid hemorrhage, where there's bleeding into the subarachnoid space. So the problem with hematomas or bruises or bleeding is that there's very little room for expansion, so that if blood starts accumulating, or if there's a bruise and there's swelling and fluid accumulating there, what happens is that the fluid obviously cannot press on the bone, and therefore it'll start accumulating and pressing on the brain, and then cause a disturbance of function in the area where the hemorrhage or the hematoma is located. Next is meningitis. So that is an infection of the meninges. So again, those three, pia mater, subarachnoid mater, and dura mater, those are the meninges. That infection can be bacterial, viral, or caused by acid-fast bacilli, so you're thinking TB, spirochete bacteria, so you're thinking syphilis, parasites. For example, there's a brain-eating parasite that can be found in waters, Naegleria fowleri, I almost forgot it, fungi, cryptococcal meningitis, for example. So these all can have a variety of causes. Generally, the symptoms of meningitis are going to be fever, headache, and neck stiffness, maybe with sensitivity to light and stuff. And so the lab test is, they'll definitely do a CBC to help determine the source of meningitis. So the CBC would only be helpful to indicate if it was bacterial versus viral, or one of those, parasitic or fungal. Routine chemistry and coac tests can be done, but simply they're screening tests. They're not going to be specifically diagnostic. You can do a syphilis screening test to rule out tertiary syphilis if that is a possibility. And obviously we're going to do spinal tap and spinal fluid analysis, in which we'll run a cell count, so get red count and white cell count on the spinal fluid. Okay, then of course that would be indicating infection or bleed. Infection would be by the white count and bleed by the red count. And then even with the cell count, it's possible to do type of differential where you can see what type of white cells are actually present in the spinal fluid, if any. And then spinal fluid proteins and glucose. So these, if there is something going on, an infection going on, the protein levels would be elevated because of the antibodies and or the presence of bacteria and fungi, etc. And the glucose levels could be decreased, especially if the organism that's present can metabolize glucose, and it can drop that glucose. And then also do cultures and gram stains, and there's also some more tests that can be done that are more like antigen tests and panels and meningitis panels, where you can check for quite a few different causes of meningitis all in the same panel. Encephalitis is a viral infection of the brain, and so this is meningitis isn't a meninges, this is in the brain itself. So we've moved on a little deeper here, and so the symptoms of encephalitis are going to be fever, headache, neck pain, nausea, vomiting, and personality changes. So some of those symptoms do overlap with the symptoms of meningitis. For lab testing, spinal fluid studies are going to be performed in order to find the cause of the disease. Again, same test as for meningitis we just mentioned. So the studies, again, often include a cell count, so white count, red count on the spinal fluid, the protein and glucose in spinal fluid, but then also some of these other viruses. Those viruses are likely to cause encephalitis, and some of those that do are going to be herpes simplex virus, West Nile virus, and cytomegalovirus, CMV, and Epstein-Barr virus. So these are all ones that we want to screen for. And current practice now is to perform PCR analysis when available for these viruses because viral cultures could take up to 3 weeks. It is also possible to test for antibodies to some of these, obviously. Next is CREUTZFELDT-JAKOB disease. Also, it's basically the human form of mad cow disease. It is caused by prions. Prions are misfolded proteins. And it's the PRP protein in the brain. It is transmissible, as in it can, it's contagious in a way. And so some of the ways that it can be transmitted, one would be to eat meat that has been tainted and maybe contain, like hamburger meat or something, contains some brain tissue, and especially if that's eaten raw, which is, again, a cultural thing. Some cultures eat that. And, that can be transmitted into humans, and then it can be transmitted from cow to cow also, not CREUTZFELDT-JAKOB, but mad cow disease. But then CREUTZFELDT-JAKOB can also be transmitted through surgical instrumentation, even if they've been properly sterilized. So there was a case a few years back where there were I think 19 cases, and they were all tied to surgical instruments. These prions, these misfolded prion proteins, cause large open spaces in the brain, so the brain basically turns to Swiss cheese. There's no single diagnostic test. The spinal fluid testing on the brain, you can look for brain-specific proteins, such as protein 1433, neuron-specific NOAs, and tau protein can help in the diagnosis, but you can do maybe a brain biopsy. Ultimately, this is usually confirmed at death that indeed it was, a prion disease. There's a little activity for my class. We're going to skip over that. All right, so let's look at a case. So Natasha is a 25-year-old woman. She's experiencing blurred vision, fatigue, poor concentration, and speech issues that have spanned a 2-week period. Seems to be resolving, but has not gone away. During the next 3 months, she has other unusual symptoms, including fatigue, weakness in her right arm, and muscle spasms in her fingers. Her provider treats the symptoms. When the muscle weakness in her legs, spasm in her foot, and general weakness occur at 6 months, her provider decides to do an in-depth workup. So her lab results are going to be a normal glucose, a normal BUN, a normal creatinine, a normal sodium, potassium, and chloride, normal bicarb, phos, and calcium. Everything seems normal. Total protein looks good. Albumin looks good. Alkaline phosphatase is slightly up, but pretty good here. LDH looks normal, maybe slightly increased depending on what your cutoff ranges are. CK is totally normal. AST and ALT normal. Cholesterol is good. She's less than 200. Triglycerides could be slightly better. Usually you want them less than 150. And HDL is good. And so, although ideally you want it above 60. And then the serum protein electrophoresis shows oligoclonal banding, which are bands in the gamma region. So again, the proteins, serum protein electrophoresis, you would have an albumin band, and then alpha globulins, beta globulins, gamma globulin bands for all the various proteins that are found in blood. Gamma globulins are going to be antibodies, obviously, and so there are bands in this gamma globulin region. So first, which one would you say might be her diagnosis? So just based on what's going on, signs, symptoms, which one would you go with? So it could be any of these. We'll talk about it in a second. And then of her lab tests, if you listen, you probably can answer this. Which one of these was abnormal? So a lot of them were completely normal. Which one's probably the most relevant abnormal lab test? So is it glucose and electrolytes? Was it the renal function, liver function, lipid panel, or the protein electrophoresis? Okay, so we're going to table that and get back to it here in a second. We're going to look at several diseases, but just be thinking about what you think might be going on with this case. So dementia is a chronic disorder. The risk for dementia increases with advancing age. Causes can include neurodegenerative and vascular diseases. And so there's a lot of different types of dementia out there. What do we do in the lab? We'll do CBC, glucose, renal and liver function, syphilis, vitamin B12, and thyroid function testing, because all of those can impact brain function. And again, you can never know, they may have tertiary syphilis. Diabetes can put you at risk of quite a few different brain diseases, including dementia. And so we'll do all of that. Alzheimer's disease is a specific dementia, so it's a neurodegenerative dementia. And what happens is there are amyloid deposits and intraneural deposits of tau protein. And then those basically, if you think of it, it's like a gumming up of the system, just like the sticky proteins that are in there, and it causes loss of function and problems. Patients can have mild, moderate, or severe Alzheimer's, depending on where they're at in the stage. And what we do in the lab is basically rule out other diseases. There's not a specific diagnostic test yet for Alzheimer's disease. Parkinson's disease is another degenerative neurologic disease. It involves the basal ganglia, and because it involves the basal ganglia, it's going to cause symptoms of tremor, difficulty walking, shuffling gait, etc. There's a lack of dopamine in patients with Parkinson's disease in that area, and so therefore that causes faulty nerve transmissions, which then causes the signs and symptoms. Interestingly, so Parkinson's tends to happen more to men, and Alzheimer's more to women. That doesn't mean that women can't get Parkinson's or men can't get Alzheimer's. I'm just saying, just in the statistics, that's kind of, men tend to have Parkinson's, women tend to have Alzheimer's. And there's another fun thing is that when a Parkinson's disease patient cannot walk properly and have trouble walking, if you put music on, they can actually walk to music, almost dance, way easier than they can walk easily. So what lab tests? There are specialized spinal fluid studies that can be performed to aid in the diagnosis, but basically there's no lab test to diagnose this disorder either. Amyotrophic lateral sclerosis, also known as ALS or Lou Gehrig disease. It's a degenerative disease of motor neurons. It is incurable, and there's only a 3-year survival rate. And so initial symptoms are going to be tripping, stumbling, and reduced dexterity. And the advanced symptoms are going to be muscle atrophy, spasticity, and contractures. Most testing in the lab is going to be used to rule out other diseases. You can do anti-ganglioside M1 antibody, and it is seen in some ALS patients, but not all, so it's not a diagnostic test. There are some genetic tests available, but again, appropriate counseling is necessary to interpret those tests properly. So again, no just magic bullet diagnostic test for this one either. Multiple sclerosis is an autoimmune disease that destroys the myelin sheath, and symptoms are of different neurologic deficits, and then there's a remission, and then there's relapse and remission and relapse. And so this is actually what our patient has. Our patient has multiple sclerosis, so that's Natasha's diagnosis. And how is this diagnosed? So definitely clinical findings along with some ancillary testing. So the fact that a lot of her other stuff was normal and her protein electrophoresis was abnormal. So again, the regular CBC, CMP, lipid panel, all that, nothing's going to be revealed in there. So spinal fluid studies are not always necessary in suspected MS patients because MRI studies, imaging can confirm the diagnosis. So that's more valuable than anything. But if the MRI is unclear, then we can do spinal fluid testing to look for the oligoclonal bands and where IgG production can be performed. So basically, the oligoclonal banding from the spinal fluid test then indicate that there's IgG production going on in the brain, meaning antibody production in the brain, and that would be an evidence of the autoimmune process of multiple sclerosis. Next is Guillain-Barré syndrome. It is an acute autoimmune disorder. You see anti-myelin antibody, so similar to multiple sclerosis, right? And attacking myelin sheath, except this one is acute, it doesn't develop slowly. And it's usually a response to infection or immunization. So this is one of the risks of routine immunizations is Guillain-Barré syndrome. The lab test, again, lab testing does not offer much in terms of diagnosis. Spinal fluid studies can be helpful. Most patients will have high CSF protein with normal cell counts. So again, indicating that inflammation that's involved with this production of antibody and the fact that it's an acute autoimmune disorder. So a rise in the spinal fluid protein with subsequent punctures, lumbar punctures, and with the white cell remaining normal, that would be suggestive of Guillain-Barré syndrome and not an infection. So again, another little activity from my class, skipping through that. So now we're going to talk a little bit about spinal fluid collection and distribution. So the spinal fluid is collected by lumbar tap, spinal tap between the L3 and L4 vertebrae by a physician. While it is collected, the spinal fluid pressure is measured, and generally 4 tubes are collected, depending on the amount that is coming out that can be collected coming out of the needle. The tubes need to be delivered immediately to the lab, and testing must commence immediately. Normal spinal fluid is going to be clear and colorless, and these are the types of tubes that are usually used to collect spinal fluid, and they usually have an etch number of 1, 2, 3, 4, and the physician is supposed to collect it in that specific order. So now let's go a little bit more. So it is important to differentiate a traumatic tap from a hemorrhage. So traumatic tap meaning the lumbar tap causes some bleeding and some blood to get into the sample. A hemorrhage means, of course, that the blood is actually already in the spinal fluid because there's a bleed going on in the central nervous system. So in a traumatic tap, the amount of blood will decrease with each subsequent tube. And xanthochromia, which is the presence of a yellow or pink color in the tube, would not be present. In a hemorrhage, the amount of blood remains the same in all 4 tubes, and you could see xanthochromia, again, a pink or yellow color, and a D-dimer test is often positive for hemorrhage. So, again, this is going to depend on which textbook you read, how things are done in the lab that you work at or that you're going to be working at. So generally, to me, the rule of thumb is when in Rome, do as Romans do, meaning follow your own lab's protocols. So CSF microbiology could be doing tube 1 or 3. Routine testing will include a culture and a gram stain. You can do cryptococcal antigen testing, and you can do viral cultures, AFB testing, VDRL testing, and PCR testing. Tube 2 generally goes to cytology. Again, so where do you use 1 or 3? The idea is with tube 1, you could have some skin contaminants. So usually 3 is better for micro. But for example, you could use 1 for some of these antigen tests or viral cultures, etc. So chemistry tests can be done on tube 2 or 3. And for example, if you wanted to use tube 3 for micro, what you could do is use tube 3, go set up the microbiology, get all that taken care of, and then with what's left, take it to chemistry and test it in chemistry. But you can also use tube 2. So in chemistry tests, often the CSF protein and glucose are done, and looking for abnormally high proteins or abnormally low glucose. You can also do spinal fluid lactic acid, LDH, IgG, CRP, tumor markers, and electrophoresis and myelin-basic protein. Electrophoresis and myelin-basic protein, you're mostly going to be looking for possibly autoimmune, multiple sclerosis type processes here. Tumor markers, obviously you're looking for cancers. CRP is a general indicator of inflammation. IgG just means antibody production in the central nervous system, so that could mean autoimmune, but it also could mean an infection and stuff. And then, yeah, lactic acid and LDH, that would be anaerobic metabolism. LDH can be increased with destruction, and it's in pretty much all the cells. So LDH is kind of non-specific. So, and of course, if IgG is up and CRP is up, protein levels are going to be up in the spinal fluid protein. If there are organisms present that are metabolizing glucose, and that glucose level will be low, so that would be in meningitis. But if it's viral or if it's autoimmune, you would expect the glucose level to be normal for that spinal fluid. So spinal fluid hematology should be done on tube 3 or 4. Again, you usually don't want it on tube 1 because, especially if there's a traumatic type of something, some of the blood could be simply a contaminant. So we do a CSF cell count, so red count and white count. Usually uses a hemocytometer on the microscope. A white cell differential can also be done. Of course, what has to be done is the spinal fluid has to be stained with a right stain. The red count is done on a hemocytometer also. And if malignant cells are seen, then it needs to be sent to cytology. Usually cytology is done on tube 2. So again, some notes on the order of tubes. The tubes that are used for spinal fluid aspirations are pre-numbered 1 through 3 or 1 through 4. Tube 1 being the first tube to be filled. If possible, tube 1 should be reserved for non-routine studies, again, because it could be potential contamination of skin or stuff, although all that's supposed to be clean, etc. Tube 2 can be used for immunology or chemistry testing. Tube 3 can be used for microbiology testing. Hematology analysis is typically performed on the last tube collected, which could be 3 or 4, to assure that, again, any peripheral blood that could have contaminated the sample during the lumbar puncture has cleared. If only 3 tubes are obtained, then tube 2 is often reserved for micro, and tube 3 is shared between hematology and then chemistry and immunology testing. So again, abide by your own lab's protocols. Some of these guidelines I got off of Media Lab, and so it just kind of gives you some ideas of what's going on here. All right, and that's it. If you have any questions, feel free to drop them in comments. I appreciate your time and attention, and hope you have a good day.